what we'd like to do is challenge you a little bit. Now, I think a key thing is, having discussed all the definitions of viability, I've given you a flavor today. There's a huge amount of material with regards to it in chapter 2 on the website. But I think what we all agree is we have to have some stand as medical professionals. We have to agree based on our setup what we think we can support with medical intensive care. And the reason for that is, obviously, when we start then crossing those limits or trying to, I would say from our perspective, challenge those limits, we would be in a situation where we might be offering medical intensive care to babies, who then encounter a lot of suffering with the risk that they're not going to survive, or that they're going to survive with very, very poor neurological outcomes, which then impacts their quality of life later on. And what we know is that if you look at different countries and different societies, and I have given you the guidelines for management at limits of viability for 18 countries in chapter 3, you will find that there is a huge variation in how we address management of limits of viability as medically defined. But more importantly, from our perspective, management is not governed just by gestation alone. There are huge aspects which include antenatal bioethical deliberations and perinatal evaluations that are made in different ways that vary between those countries. In some countries, culture is very, very important. What the parents want is very, very important. In other countries, the medical professional tends to make those decisions based on the best, I would say, the best interests of the baby. And clearly, what you can see is this variation in practice. It's quite challenging. I find it incredibly challenging because I practice in a certain way. But clearly, the challenge for me is, if I then have parents from a different country, something that we're going to do today is the workshop, what do I do? How do I address that situation? What should I be doing? But what we normally say is that for most Western and high-income countries, a decision to resuscitate any baby, say at 22 or 23 weeks, is guided by a perinatal evaluation by us as a team. So that's the obstetric team, the midwifery team, I would say the medical team. If there is other pathology, it might involve other specialists. But clearly, we would have, I would say, bioethical deliberations based on guidance that's available in our setup. We would discuss the potential survival outcomes, neurodevelopmental outcomes for that, I would say, couple, mother-baby dyad, as an individual. And we would try to then speak to the parents and get an estimation of what in their mind they think they would like to do for their baby. Now, clearly, the concept of gestation alone as a marker for us determining how we resuscitate babies is something that is still practiced in a large number of countries. But what we will now be able to see, and in particular with the new BAPN guidance and guidance from Victoria that I've just recently updated the website from, gestation-based criteria are actually being looked at in a slightly wider perspective by looking at factors that actually might improve the survival of the baby or might actually make the chances of survival less. Now, to give you an example, factors such as sex, prenatal optimization strategies like steroids, giving the baby magnesium sulfate, are things that result in better outcomes. So, we all know that girls are, for some reason, have much better protoplasm as compared to boys. At the same time, if you give steroids, you improve, reduce the rates of IVH, you improve lung maturity over 26 weeks, reduce rates of IVH pretty much from, I would say, 23 weeks onwards. So by using these strategies, you can improve survival outcomes. But a 23-week girl who weighs 700 grams, who has had steroids, might be much better from a survival perspective and have less morbidity, as well as a better neurodevelopmental outcome as compared to a 24-weeker boy who is severely IUGR and growth restricted. Now, the question is, from our perspective, if we just use gestation-based criteria in those circumstances, we might agree to resuscitate the boy, but not resuscitate the girl. So the chances for the survival of the girl and outcomes are actually better. Now, that is a paradox in itself. So I think a lot of, I would say, neonatologists and ethicists, in particular, a colleague of mine, Dr. Dominique Wilkinson, talks about gestational ageism and the importance of trying to, I would say, individualize the chances of that baby, not just based on its gestation, but by looking at its chances based on factors that either make it better, female, uh, you know, uh, a baby that's well grown, the absence of infection, uh, looking at those factors, and then looking at an active approach to trying to manage that situation by provision of steroids, magnesium sulfate. So again, lots of other factors in addition to gestation to try and quantify what we think is right for that baby and that mother baby dyad. Now, clearly, uh, you know, there are other strategies that are also involved in management of pregnancy, and it might be that those strategies impact the mother's health, and we have to then consider, I would say, the risks to the mother's health of adopting a very active strategy in a baby that's extremely preterm. But what we've got to do is bring this all together, having discussed it as a team, obstetricians, us, the midwifery team, and adopt a decision making strategy that we can then discuss with the parents. Now, at the lower end of the spectrum, what I would say is most guidelines on management of, I would say, thresholds of viability in Western countries espouse what I would call is a shared care decision making approach. And that means that we would speak to the parents in a completely non judgmental way, taking our personal values out of that conversation, taking our personal feelings, our moral distress out of that conversation, trying to give them, I would say, a completely honest opinion about the objective chances for survival of that particular baby, for the potential handicap that it might have in terms of neurodevelopmental outcome, but with the knowledge that being absolutely certain that that will be the case for this individual pregnancy is very, very difficult to predict. The parents would then listen to that. You would give them time, more time if they need, more information if they need, to try and come to a decision making strategy about whether or not they would like resuscitation, especially towards the lower end of the spectrum. And from our perspective, that could end in, I would say, actually three outcomes. I've written two over here. So one of them would be a trial of life. Now, a trial of life would kind of, from our perspective, mean that we, in my setup, I would say we actively manage that pregnancy. An active management for me would mean that, you know, if that baby was 23 weeks, it was a girl, steroided, good size. I think from my perspective, I would definitely recommend steroids. I'd definitely be recommending magnesium sulfate. If there's infection in the background, I would definitely be recommending that we treat with antibiotics. But at the same time, if there's any way that we can get that pregnancy forward without either compromising the mother's health or the baby's health, I would also recommend that we try tocolytics. So the active approach starts even before the baby's born. What we're trying to and aiming to achieve in this particular situation is actually the baby being born in the best circumstances possible so that we can give that baby a good start to life. And then we take over from there and we look at care of the baby from that point onwards, with the knowledge that we can't predict outcomes with certainty. What we've got to agree is, despite our efforts and even giving babies the best possible start, some babies, depending on gestation, will not do so well. And if that is the case, the parents do have a choice here. And if they opted for comfort care, then what we would look at is giving them that choice. But we have zones of discretion. And if you look at the guidelines produced in Victoria, there are certain, I would say, survival figures or neurodevelopmental outcomes, which from our perspective reach a threshold at which we would recommend resuscitation. And it's really interesting. That also varies from country to country, even amongst Western countries. But what I've done is I've given you an approach, just a generic approach that we would follow over here. What does this look like? So this is a flavor of what it might look like. So we have a family who has a preterm baby at threshold of viability based on your individual setup. So, Lever, I was going to ask you, what is the threshold of viability in Belgium at the moment? I mean, how I would say, uh, lower baby in terms of gestation would you feel comfortable resuscitating? Sorry, you're going to have to unmute yourself, Leva. I'm so sorry.
I don't really know for Belgium at the moment. I haven't done there any neonatal medicine since 2015. So at the moment, I don't know. But when I was there, it was 24 weeks.
Okay. And if you had parents who wanted resuscitation of a baby at 23 weeks of gestation, what would the approach be?
It was in 2015. I think that would not be encouraged. But if the baby was clearly alive, it would probably be tried.
Okay. That's great. Just curious again. I mean, for babies at 24 weeks, what would active care be for you in Belgium in 2015? Would that mean steroids, magnesium sulfate? Okay. Yeah. And if the parents didn't want resuscitation at 24 weeks, say, what would your approach be? Would you be comfortable with that in 2015?
If I've had one case like that in 2015, it felt very uncomfortable, but I don't think we would have been successful even if we had tried to resuscitate that baby in that case. But it felt odd because we had to be in the delivery room and just be there and not do anything. Well, we ended up drying the baby and wrapping it up, but yeah, it felt strange, but that was not a baby that had survived even if we had tried.
So I can give you an example of a similar situation from the UK where we had parents at 24 plus weeks of gestation who were very uncomfortable having a baby with any disability. Now, the problem is when we antenatally counsel parents like that, even if the pregnancy carries on, there is a small risk of disability even at 28 weeks. Now, it would make us, and I'm sure you'd be very uncomfortable not resuscitating a baby at 28 weeks. So the question is, why should that change at 24 weeks? Now, I think the question there is, it's looking at that pregnancy like you did as an individual and looking at everything and actually trying to quantify survival. And in our situation, what we had was quite severe oligohydramnios, very severe. What we also had was very severe and significant APH that had been there from a very early time in gestation, as early as about 15 weeks, countered by the fact that, we had other factors, all of which, meant that actually 2 neonatologists and 2 obstetricians agreed that we would be supportive of that approach. And this is in 2011. So, what I'd say is that, it wasn't different for us at that time, as it was for you. Gautam, can you hear me? Okay, Gautam might not be able to hear me. Emmanuel, can you hear me? You would hear me. Okay, so what I'm going to do is I'm going to talk to you about a gestation-based approach at this particular point versus a beyond gestation-based approach, and give you a little bit of a flavor of how they differ. So what you will notice from our perspective is that whenever a mother-baby dyad comes to us at, say, threshold of viability, there will be a need to try and make a judgment about the gestation of the baby. Now, for all practical purposes, if there's been a dating scan done before 13 weeks, the accuracy of being able to predict the estimated date of delivery is, I would say, plus minus 5 days, as reported in the literature. So, accurate. If you had the LMP and the mother actually remembered it accurately, then I would say a combination of both those things would try to help us make the best estimate of what we think the baby's gestation is based on its due date. Based on that discussion, I think what we would then do is we would go back through the pregnancy and we would look at other factors, as we've discussed, that in addition to gestation, make the prognosis for that individual baby better or worse. And if you look at the literature, there's a variety of things that is documented that we will talk about when we come to survival in chapter 5, which actually might help or might actually hinder the chances for the baby. In particular, sex. So as we discussed, boys have poorer protoplasm. You could argue that actually 22-week boys should not be resuscitated at all. Then one might say that we can kill all the boys and there'll be no preterm boys left at all. But I think what I'd say is plurality is the other thing. So twin pregnancies and within IVF pregnancies on the rise, in particular in a large number of, I would say, even developing countries, there are complications that arise with multiple pregnancies, which can affect prognosis. The state of the pregnancy at that time, whether there's an element of perinatal compromise, what is the clinical condition of the baby and its lico, is it moving? What is the Doppler? What is the umbilical flow like? Is this baby severely growth retarded, compromised from a nutrition perspective? Are there infections, or is there another congenital problem that actually will impact this baby's chances, which then will obviously weigh into how we make an assessment during bioethical deliberations of this baby's ability to survive and its long-term outcome. What is very, very interesting from our perspective is there has been a huge amount of work done by Nina Modi and her group, colleagues in Australia, and clearly babies who are outborn. I would say babies who are born in centers that are not level 3, say level 2 centers or level 1 centers in the UK. But also, if you go to countries like India, babies born outborn in those particular setups, they are in extremely difficult situations, and their outcomes are not as good as babies who are born in tertiary centers. So while there has been a huge move to try and centralize delivery of babies at extremes of viability, there has to be a recognition that this is not possible in certain countries. I mean, in India, my tertiary center had a catchment of nearly, I would say, 4,000 miles. That's massive. So we have no neonatal transport. So if you have a preterm baby delivering in a level 2 center, it's going to live and die over there. But if you're in the UK, say, for example, people would try to optimize and allow delivery in a tertiary center by shifting the mother there. The question from our perspective is, what if a 22 or a 23 weeker in the UK delivered outborn? How would you approach that? What would your recommendations be, especially if you can't move the mother? So all of these factors, in addition to gestation, impact our discussion with the parents. Now, we discussed the outcomes. So there could be a decision for a trial of life. There could be a decision for palliative care, say at 22 to 23 weeks. I think if you come to the UK, what you'll find is most of us would opt to resuscitate babies at 24 weeks if, given the options. But more importantly, there might be special considerations in situations where you might opt to terminate a pregnancy if it's legal in your setup. And, if you want to start resuscitating a 23-week or a 24-week baby with a left-sided congenital diaphragmatic hernia, the outcomes for a male baby like that will be less than 5% survival. So experience says that you've got to contextualize all these factors and then come to a decision about how you're going to manage the pregnancy, discuss that with the parents. And I've got 4 approaches that I'm going to take you through here, one of which is current, 3 of which are current actually, and one of which is slightly old. So the guideline that you see in the left upper corner is a guideline that I've got from Southern Australia, which uses the PAGE framework for trying to actually assess the chances of survival, but a gestation-based approach. And clearly at that particular point, and this is Southern Australia in 2013, the survival chances for a baby provided with intensive care at about 22 weeks was less than 10%. So for them at that particular stage, treatment was not indicated. So life-sustaining treatment would not usually be provided. On the other hand, to give you a flavor, the Victorian guidelines have just been published in 2021 and been made available to me by Rosemary Boland from Victoria. What they say is that actually we have to take an approach which does not consider gestation in isolation, but actually considers things like place of birth, the estimated weight, sex, plurality, presence or absence of congenital abnormalities, and perinatal optimization. And actually then consider the chances of the baby. And actually, if you had a well-grown baby at 22 weeks, say, of gestation, who is 22 plus 5, who's a girl, and if you look at the guidelines, then they would actually recommend active intervention based on bioethical deliberations to that family. A very similar stance is taken by the British Association of Perinatal Medicine, where they've looked at a continuum between 22 and 26 weeks of gestation, where the risk as you approach 22 weeks becomes very high for a poor outcome, survival, as well as the risk of a very, very abnormal neurodevelopmental outcome. But as you advance with gestation and look at risk factors, the chances actually improve. And they have, again, advised on an approach which involves shared care decision making in such circumstances to counsel parents. So, what you can see is that a lot of the guidance at this particular point is moving beyond just the gestational based approach. Having said that, there are states and countries who still follow a gestation based approach. Uh, at the moment, I would say that if you look at countries like Denmark, I would say where management is relatively conservative, they have stuck to keeping gestation as a cutoff. And I think the reason for wanting to bring that back in is you have to have some cutoff at which you are going to say that medical technology, intensive care, plus minus resources have got to be factored into how we resuscitate babies. Some countries are happy having those discussions with the lay public, making those laws, I would say through parliament, to be able to make guidelines that are then understood by society. And I would say that countries like Denmark have, and I would say to an extent, the Netherlands, they've adopted an approach where they've been able to have these discussions and actually agree that gestation at this particular point is perfectly reasonable a way to be able to assess uh, their ability to be able to resuscitate babies. But I think what you'll find with the literature evolving is everybody's starting to think about whether we move beyond gestation. Now, clearly, we talk about gestation, but we don't resuscitate babies under 22 weeks. So, what's to say that a baby at 21 plus 5 weeks of gestation is not 5 days off by ultrasound, is a girl who's 700 grams in weight and actually will do better than a boy who's 23 plus 1 who's 410 grams of weight? And I think that's where I would say that between these two approaches, what different countries have tried to do is adopt strategic guidelines to guide them in their antenatal bioethical deliberations, with the knowledge that this is evolving with time. And it's a very interesting time to see how things are moving forwards. Now, I've given you a flavor of how we might approach gestation, and that if the pregnancy, a preterm pregnancy at limits of viability comes to you, there's going to be an assessment, a prenatal assessment. There's going to be neonatal obstetric deliberations. We're going to consider our current national recommendations. Some centers like to consider their local survival figures. They like to look at survival not just nationally. Some centers also like to look at, I would say, what they are doing in terms of managing babies from a research perspective. So certainly, uh, if you look at Germany, say for example, they have been able to centralize the management of 22 weekers. So Cologne actively manages babies at 22 weeks and has been doing so for an extended period of time, even though that's not routinely recommended in the German national guidelines. So, there are centers of excellence who have agreed that unless you actually adopt a strategy of actively resuscitating babies like that, how do we then give parents an accurate picture of how a 22-weeker is going to do from a neurodevelopmental perspective? Because actually you're self-selecting some babies to die based on choice and not actually offering them active interventions. So it's a little bit of a minefield when you go from country to country, but clearly there is an approach. And I would say that that approach eventually ends with shared care decision making with various degrees of, I would say, the word I would like to use is uh, a spectrum of paternalism to a spectrum of parental autonomy. And I would say that I don't think that at this particular point we can define for any particular culture of setup what is appropriate for them based on the literature. Each country has to go back and look at parents as individuals based on their culture, their values, and their religious beliefs, their understanding of viability as a concept, and then kind of decide how they're going to approach these conversations. Now, with that in mind, Leva, I'm going to give you a little bit of a scenario. Can you see the scenario?
Yes.
See, yeah.
Okay, so I've got Kenechku as well. So Gautam, can you see the scenario?
Yes, I can.
Fantastic. Okay, so what we're going to do is, this is a scenario that I'm going to give to Leva. Now, Leva currently works in the UK. So we're going to get her to think about management of this particular case from a UK perspective. So this is a mother from India. She's single. She has been working as a waitress on a cruise ship, which is commonly docks at Southampton in the UK. She went into very early labor at about 25 weeks of gestation. Clearly, from her perspective, there were no facilities on the ship for doing an ultrasound, but she managed to reach Southampton, which is a tertiary center, have an ultrasound, which actually shows that she has a singleton baby girl who's 700 grams in weight, really good movements for the baby, good amounts of LICA. There is really good Doppler flow. She's kind of in a situation where the baby is well grown at 700 grams in weight and doesn't appear to show any signs of fetal compromise. Based on our antenatal bioethical deliberations, we discussed and have given her steroids because she's in very advanced labor. So actually she's bulging membranes about 7 centimeters, likely to deliver quite soon. We don't think that magnesium sulfate at this particular point she will be able to manage, in that we might not be able to get it in time, but we're going to try. So the one thing that the mother has voiced when we went to speak to her about how we manage her pregnancy is that she's extremely poor. She's a single mother. She doesn't know who the father of this baby is. She can't afford the cost of private healthcare, either in the UK, and certainly can't afford the cost of, healthcare, survival, transport to India. She's also very worried because somebody's told her that babies under 26 weeks have significant problems later on in life. And based on all of this, she doesn't want this baby resuscitated. So would you like to talk me through how you're going to approach this?
Yeah, so I think we would have a discussion with the obstetric team and the neonatal team and make up our mind. Obviously, we already know that mum has voiced certain concerns and certain ideas, but I think it would be best to have a medical team to have a shared idea that that everybody says the same thing to this mother, and not somebody says all babies under 26 weeks die and the others say, oh, she's actually got a good chance, because that might make the mother even more confused. But if you look at the factors purely from the baby's point of view, I think this baby's got a very good chance of survival. It's got a lot of favorable factors. But then if you look at mum's point of view, she does not want a disabled child and can't afford private healthcare. These are two things that are actually quite opposite ends of the spectrum. So it will be a difficult decision to make.
So I'm going to give you 5 minutes just to have a think about how you're going to approach this. And the 4 things we want to consider at this stage are: A, would you recommend resuscitation versus comfort care? Number 1. Number 2, if you recommended resuscitation in these particular circumstances and the baby was born in poor condition, would you give this baby compressions, adrenaline? Number 3, say if this baby survived and the mother was in this situation, how are we going to actually organize support? And a good example is she would technically qualify as a private resident in the UK. So how would we manage the situation? Who would pay for the care? So I'm going to give you 5 minutes. Have a think about that. And while you're doing that, I'm just going to ask Gautam. Gautam, are you there?
Yes, I'm there.
Okay. Gautam, just tell me, so if this mother was in India, 25 weeks with this baby, didn't want resuscitation, can't afford it, and, real problem, she's extremely poor, she doesn't have enough money, and you were in a public health setup, not a private setup.
Okay.
Would you be supportive of her decision?
Yes, yes, we would be, because here also, since it is a public health system, and she cannot take care of the baby later on, if the baby survives or if the baby has any disabilities, then obviously from a public health system point of view, then we would support her decision of giving comfort care as a team. I mean, after discussing with our team and our consultants, we would counsel her, and then ultimately it is. We would consider decision and start the baby on comfort care once the baby is born.
Okay.
This is how we do it here.
Okay, that's really kind. Kenichi, can you hear me?
Yes, I can.
Kenichi, if this was a baby in Nigeria, in your setup, how would you manage this? Would it be a medical legal problem? Is the question I'm asking.
Well, in Nigeria, we still use 28 weeks as our age of viability. But what we do, we consider in my center, we consider beyond gestation. So we individualize our practice. So what we're going to do for this mother and baby, one is to, if we have time, to talk to her, telling her that yes, there are chances that this baby may have problem, but there are also chances that this baby might come out and be normal. So if we have time to talk with her and be able to see if she can see things in our own light, we will. But if we don't have the time and baby is born and show chances, it will be in our sense, we will do something, we will resuscitate and see what happens. So we don't really have any medical legal grounds or problems or issues in the country. So what we're going to do is that we're going to do an active resuscitation. And while the baby is with us in the newborn unit, we will continue our counseling and even bring in the counseling unit to talk to her. Sometimes, yes, they have this idea, but when they see that the baby is doing well, because 700 grams is good, and being a female, there are chances that this baby will do well.
Kenichi, how would we address cost in your setup? So if she was nervous, I'm just curious.
The issue here is that cost is a major problem in our setup. But what we normally do is that we have a crowdfunding, and it's for the first 48, 72 hours. We'll be able to give this baby what the baby needs. And sometimes also, even when they're discharged and they cannot pay, we'll get the social workers. We'll have a social work unit that come in to see if they will help raise money for them. But our primary aim most of the time is to give the baby the chance to survive.
That's really helpful.
That's what we do.
Thank you so much. Emmanuel, can you hear me? Emmanuel might not have a microphone on that side. So Liva, I'm going to come back to you. So let's talk about the approach, those three questions. Yep.
I would definitely recommend active management because, as Kenichi said, this baby is a girl. 700 grams is all favorable factors for outcome, and this baby has a good chance of survival. So my recommendation would be active management. And then the question was, if this baby presented in very poor condition and needed full resuscitation with chest compressions and adrenaline, I would be slightly more hesitant because obviously that's a bad start, and that is not going to make the prognosis any good, and especially not if this mom has voiced that she does not want a baby with disabilities. It also depends on how extensive resuscitation, obviously, but if you're already on giving adrenaline and chest compressions, then it is very poor. So I would be hesitant to do that in this situation.
That's really helpful. So I think Kenichi wants to say something.
Oh, no. I'll go with Boel. That's exactly what we're going to do.
Yeah.
Well, if the baby comes out and is white, the chances of survival is quite poor. we will be hesitant to go all the way to resuscitate the baby. But if the chances are good, we will do our best to make sure and then deal with the cost of management later. That's exactly what we'll do.
Lovely. Liv, do you know how we'd manage cost in the UK?
To be honest, that would be referred to the social workers, and I don't know what they actually do. But I've never had a person who can't afford it because they're for private health, have to pay actually, have been kicked out or the care has been stopped. That's never happened to my knowledge.
That's the right answer. So, I mean, it's to give all of you who are on with us in this workshop a little bit of an idea that I've not known that we've ever not given care on those grounds. And like you said, it's kind of looking at avenues for charity if it's that bad. Experience says this is emergency care delivery, and management of and resuscitation of the baby is an emergency for us. And that care would be borne by the NHS. I think the question becomes as the baby survives and goes forwards, how you address those issues. But I would agree, I've never been in this situation. And I mean, this is very similar. I've obviously anonymized and changed the ethnicity of the mother in these circumstances to try and anonymize this case, but actually the cost was borne by the NHS. Now,
I just want to say something. Yeah, the issue of funding or paying bills at the end of treatment. In fact, I'm currently in one of them. I had a set of twins that I've just discharged, delivered at 27 weeks. 0.8, 800 grams and 900 grams. Was with us for 6 weeks and we've discharged. They can't settle their bill. They're still here with us. We've involved the social workers to see if they could help raise money for them to go home. So it's a regular thing here for us where we do our bit, and through the crowdfunding or pool system, we're able to sustain a baby and the baby goes home. Settling the bill is usually a big issue down here in my center, and I'm sure it's same in most of the African countries. So it's really a big issue where the insurance does not really cover everything. Not everybody gets to benefit from the insurance system in my country. Thank you.
That's really kind. So, Leva, I'm going to take you a little bit further ahead in this case and say the baby was delivered in very good condition. It was born and actually just needed CPAP, did not even need intubation surfactant. It's now 3 weeks of age. The mother, obviously, her work visa has now expired and she is being repatriated back to her home country. So she doesn't want the baby because she feels she will not be able to give it the level of care that is available to it in the UK at the moment when she takes it back home. She will not have the funding nor the money to be able to look after it, the intensive care needs of a baby who's now 28 weeks, but also subsequently, manage this baby at home based on the fact that she's a single mother. There are cultural issues with how that's perceived in India, being a single mother who's not married with a child. So she, at this particular point, how would you approach that?
Well, I would definitely be
sorry for putting you on the spot. Yeah.
I would definitely feel empathy for this mother because she is on her own with this baby and can't look after it properly. Although I think if she could, she would want to look after it. But you can't just send this baby to India on CPAP just in the plane. That's not practically possible. But if she clearly states she does not want this baby, then it's going to be a case for foster care or for adoption, I think.
Yeah, I completely agree that, this is a situation where obviously there's a consideration about what's right for baby. There's also the consideration of what we can do maybe to keep the mother here. The question is, can something be done to alter the legal status of the mother, be able to fund the care of the baby going forward so that we can keep this mother-baby dyad. But I mean, in reality, for us as individuals in this situation, foster care and adoption was the route we had to take for these circumstances. Now, one of the questions that I want to ask all of you at the moment is, when making this decision about wanting to resuscitate this baby, what was your prime driver? Is it guidance as is available locally? Is it laws that would practice, you would practice in your country? And are there any circumstances where you would not consider resuscitation of this baby? Let's say you were in India, Leave, and the situation was there, and you were the clinician in India. I'm going to put you on the spot again. So you're working on a temporary placement over there as a fellow, and this mother comes to you. So what is your primary driver here in the UK? What would you do if you were in India?
My primary driver in the UK is that I know that a 25-weeker has a good chance of survival, especially with favorable factors. So I wouldn't let this baby die. Well, I mean, I would do my best to resuscitate it. I would say I can't predict that this baby will not die. You don't know. If I were in India or in a resource-limited setting where you haven't got the resources and you know that the chances of survival are much, much less than they are in the UK, then the situation is different. And then I might agree with not resuscitating this baby, but you can't predict what this baby is going to do, because if it's the case that this baby actually keeps on breathing and like just needed CPAP, then it might well survive even in India.
Absolutely. So that's a really good, I would say, parallel planning. This baby might do very well and might survive. And it might be that actually a baby like this can survive in a middle ground setup where it's not so expensive because it does not need intubation, can be maintained on CPAP. So Gautam, I'm going to come back to you.
Yes.
Gautam, so Lever's raised a very good point. So if this baby was born breathing with a good heart rate, vigorous, crying, and you have CPAP in your setup, but the mother doesn't want resuscitation, what would you do?
At this time we would counsel her. We would talk to her that the baby can do well at this time, because the baby has had a good start. Then we would talk to her and we would make sure that the baby gets the treatment. And we would also explain to her the financial conditions also, because if the baby is also born in a public health system where CPAP is also available free of cost, then she need not have to spend a lot on other drugs also. The antibiotics are also given free, even if the baby required surfactant, which can be given by insurer. It would also be cheaper compared to if the baby was born in a private health system. So at that time, we would really bring in the social workers and the other multidisciplinary team, so that she can be made to understand the repercussions of having a better child. I mean, a child who might do well. So at that time, we would go ahead with the treatment, and we would go all in for to give proper care to the baby.
Sure. So that's really helpful, because it shows us that from our perspective, what we have to think of is the condition of the baby at birth as well. And sometimes, while we might counsel parents in a certain way, some babies may come out exceptionally, I would say, well, looking like they're screaming and shouting, and likely, there might be situations where we're ethically in a situation where we can support those babies. The question is, do we go back to the parents and how we manage it? So I think that's a perfectly reasonable approach. So if I summarize, what have we done over here? So for this mother, she's come, it's a very tricky situation, but as a neonatal team, as a group, I would say, we've had some deliberations to kind of talk about the survival chances, the risk of neurological outcomes. We haven't really addressed the risk of neurological outcomes. So I'm just curious to kind of tease that a little bit more, Leva. So what are the chances of a baby neurological outcomes at a 25-week girl who's female?
Well, in the UK, we've got the BAPM framework.
Yep.
So
I'm going to help you.
I will always have to look it up. But if 25-weeker who is doing well has got good chances of survival without neurological deficits. But for the exact numbers, I always check before I go and speak to parents because they're not sitting in my head correctly.
I agree with you. I can't remember them either. I really struggle. And, you know, the BAPM framework in the UK has come up with an absolutely beautiful infographic. I hope all of you can see it. And I mean, if you look at a 25-week girl, say, for example, the first infographic looks at the survival chances for this baby as currently stands. So she's 25 weeks. She's a female. She's good sized. I think if we optimized with antenatal steroids, she's already in a tertiary center. She's a singleton. She's growth appropriate. So all of them, you know, to me would say that actually her chances of survival, less 25 weeks, they're more like I would say a 26-weeker. She's behaving more like a 26-week baby to me. So her risk of neurodisability as described here is moderate risk. Again, we'll talk more about that when we talk about the epidemiology of neurodevelopmental outcomes in chapter 6. But, you know, if you look at the estimated infographic, it says that at 25 weeks, 7 in 10 babies survive, and 6 in 7 babies do not have severe disability. 1 in 7 babies have severe disability. Now, because we can't quantify for this baby exactly what that might mean at this particular stage, I think agreement would say that, you know, resuscitation would be in this baby's best interests. So I would say that it would be very difficult for us to recommend anything other than resuscitating this baby, unless there were other factors that made the prognostic outcome worse. And let's say that if we went back to the situation and this baby had, say, chorioamnionitis with a leaking from about 14 weeks, very, very severe APH, kind of a situation where this baby has had a CTG that's very, very abnormal. You know, the question from our perspective then is, the debate is, would you do a cesarean? How would you perinatally optimize? But the question then from our perspective is, we would have to see how the baby's condition is when it's born and resuscitate accordingly. And I think I'd agree that if it was coming down to the point of giving compressions and drugs, I would be very circumspect in my approach in management of this particular situation. So what you can see is how the availability of a framework helps guide us through antenatal bioethical deliberations in trying to judge what is the right thing for this individual pregnancy, but also taking into account the circumstances of the mother, her choices. And the approach that we would take is one of, you know, discussing this approach with the mother, but with the knowledge that we've got to respect and acknowledge those circumstances. You know, we've got to give her assurance that there is actually an alternative approach to manage a baby like this. You know, adoption and foster care is very much a part of this process, and that actually maintaining her confidentiality, you know, absolutely crucial in Indian culture for a single mother in that situation. That might be the most important thing in her mind. So having those discussions is about exploring all those frames and try and assuage her, get her on board with what we think is the right thing for the baby, but also how we might be able to help her situation and actually come to an agreement, a shared care decision that that's the right thing for the baby. It can be done in a very different way as well. So another way that you could do this in is you could say, Dr. Sharma could say, actually, it's 25 plus weeks. She's a girl with steroids. Her survival chances are really good. My recommendations say that I have to resuscitate her come what may. I'm sorry. The decision is not in your hands. How does that feel? So I can see Leva is nodding. So Leva, what do you think about that approach to communication?
It doesn't feel
it's
very
honest,
right.
but it's honest.
I know it's honest, but it feels like I'm totally ignoring the mother's perspective and her situation. So yeah.
Kenechu, what do you think?
Oh, sorry, I didn't get.
Don't worry, Kenechu. I'll ask Gautam. Gautam, what do you think?
Yes. I mean, from our perspective, from our side, we know that. From our side, we know that what you're saying is correct, but ultimately it is the family who has to take care of the child, and so I mean, I think from their perspective, I think it would feel intimidating that, you know, their voice is not heard. I mean, we're just giving our medical opinion that, you know, that you don't get to decide what happens. I don't know. I mean, I mean, I feel that, you know, that they also need to get a say uh,
Okay, fair
on how
point.
to approach.
I'm not going to put you on the spot. You know, obviously, it becomes tricky. But what I wanted to highlight is what I'm adopting is what might be viewed as a very paternal approach, where the medical clinician is the person who's right about what should happen to this baby, irrespective of the parental circumstances and choice. And what I'd say is that I'm giving you one extreme. I'm not saying it's right or wrong. I want you to make that judgment. I don't want to influence your decisions. But going forwards, as we move through all of these aspects, the last area that we address as part of our module is communication in different circumstances. And what we will be doing is giving you a flavor of the different approaches of varieties and styles of communication, which do vary from country to country, and we have to respect that based on culture. You know, so a flavor of what you might want to do might be very different. So, with that in mind, what I'd like to talk about a little bit over here is the parental perception of viability before we go on to the next case. And what I'm going to highlight to you is that whenever we have discussions with parents, say, who might not want what we're recommending, what we have to do is get a discussion focused on getting their frame. What is it that is governing their choices at the moment? What is it that, from our perspective, we we need to do to, I would say, get them on board with decisions as a shared cared approach? Because it may well be that some of these factors actually we can actually manage, we can help the parents with in coming to a decision where they either, based on their beliefs and values, don't feel guilt, something that's really, really, you know, difficult for parents when you come to making decisions at limits of viability. At the same time, what we've got to realize is that there might be a religious, I would say, background to their refusal for a particular approach that the medical team is presenting to them. And the question from our perspective is whether we can take those feelings, acknowledge them, but actually discuss how religion interprets these things, uh, with a view to trying to, again, get a middle ground with regards to how we manage that particular situation. So it's really important to look at these aspects. So we talked about values, and when I talk about values, there will be parents who feel very strongly about not wanting a child with disability who has a poor quality of life. Now, when you talk about that in the context of a 25-week girl, where we said that the chances of severe disability are 1 in 7, that 6 will go without it. The question they might ask you based on their values and that thought process is, what if our baby is that one baby? What if it's that one baby who ends up severely disabled with a poor quality of life? So I'm just curious, Kenneth, did you hear that?
I did. It's quite a difficult situation, and being talking from the religious ground, nobody plays God. It's talking to them and agreeing with them. Like you said, it's a shared decision, shared responsibility. You don't know which baby is going to be that one. Why does the parent think that my baby is going to be that one? So it's something that you need to do a lot of talking, and say. And one of the reasons why they have this kind of impression is what they have read, what they have heard. So we just got to give the baby a chance to see what comes out of it. I have a baby recently. This is a preterm baby, 35 weeks, oh no, 34 weeks, a set of triplets. One came back after discharge with fever. We thought it was meningitis. We treated, but the child still has a hydrocephalus, and they've done a shunt operation. So it can be anything, but the most important thing is giving the baby a chance. That's what I think, and that's what we really do here. But we need to carry the parents along in whatever decision that we take or that we are taking. Thank you.
That's really helpful, Kinechu. Leave, how would you answer that question? You know, what if our baby ends up severely disabled, ends up being that 1 in 7?
It is very difficult, and you can't predict from the start who is going to be that 1 in 7. Therefore, you can't decide not to resuscitate all of them to prevent one that is going to be severely disabled. But I know from experience of a friend who's got a preterm baby who's severely disabled that it's tough to live with. So I would totally understand that parents say, we don't want something like that. But you can't predict it. And yeah.
I think, Gautam, I'm going to put you on the spot now. How would you answer that question?
I think I would have to agree that we can't predict which baby is going to be disabled or which baby is going to come out wonderfully well. So at that time, I mean, we can ask even if we have a child who is disabled, we can give. I mean, we can have a support group, or we can talk to them and tell them that this is not the end thing. I mean, because ultimately, like just because they feel that they might have the 1 out of 7, we cannot not resuscitate the baby. I mean, is what I feel.
Yep. So one of the things that you've all espoused really nicely at this particular stage is the fact that certainty with neurological outcomes is never there. You can't use statistics to predict what the outcome is going to be for this individual baby. But what you can do is you can use the literature, you can use your local outcomes, and you can use your own experience to be able to guide parents in those circumstances. You can use the experience of colleagues. And the reason I say that is because it sounds relatively straightforward at 25 weeks, but there might be situations where you've got a 25-week baby with a diaphragmatic hernia, and the situation becomes very different in those situations. So lots of approaches to it. The one last thing that I wanted to kind of talk about is socioeconomic factors. And in developing countries, I can't emphasize enough how this impacts, parental choice. And, while we have a public healthcare system in the UK where we're able to fund everything, I mean, I can use as much nitric oxide as I need on as preterm a baby as I need to. But I think, when it comes to somebody in a country where you don't have a public health setup, everything is extremely expensive. Now, the reason I'm talking about this is because we talk about perinatal optimization, but there are parents who will not be able to afford magnesium sulfate. There are parents who will not be able to afford giving the mother antenatal steroids because of the cost factors related to it. So actually, poverty might actually impact our ability to optimize the 25-week girl's chances in India. At the same time, you might find that this is a family who is going to sell all of its land and not be able to even get a staple meal a day in order to try and sustain this baby in certain situations. Now, those are not things that we can ignore. It's something that I don't have an answer to, something that I think we will talk about a little bit more when Dominic speaks to us. He's one of our ethicists. And, it's a question that even I would like to ask him, but it's definitely something that impacts how we deliver care in resource-limited settings where parents have to pay for the care of extremely preterm babies. There's just another aspect that I want to talk to you about, and this is, again, an aspect that we often encounter in the UK as well. And this is just a study that's been done by Alvin Tan in Australia. And they looked at a questionnaire which looked at a survey of parental and clinician perceptions around when intensive care should be provided for extremely preterm babies born at limits of viability. Now, the intention of this work was to look at the threshold at which parents would become worried about initiating resuscitation for that baby, either because the risk of disability is very high or because the risk of mortality is very high. And they asked exactly the same questions to the clinicians. Now, the question from our perspective is, We read guidelines, we have guidance, we have experience. We have all of these things with us. We follow up children, we have our follow-up data, we have national follow-up data, we have international studies, and we take all of this, and what we try to do is we try to apply it to each individual family as best as we can. But what we must realize is that our perception of survival and our perception of neurodisability might be very different to the thresholds at which the parents might want intervention. And to be honest with you, this can go either way. So just to give you an idea, I mean, this study, which was done in 2020, and again, this is available on the website, it's a Mendeley article. When it compared the responses of physicians and parents, what they realized was that actually parents were quite happy to tolerate a higher risk of mortality as compared to physicians. So the median mortality risk at which parents did not want further resuscitation. And again, the reasons for this were quite varied. You know, some parents worried about the risk of suffering, but they were quite happy that as long as this risk was not higher than 90%, they were happy to do and go for resuscitation. But once this risk approached or became more than 90%, they did not want resuscitation. This is just mortality, and it's a median. So if I give you an idea to say there is a spectrum. Having said that, when we looked at disability, they were quite anxious and averse to accepting even a 50% chance of a major disability, blindness, significant cerebral palsy, mental development index, you know, as quantified to them in very, I would say, colloquial terminology. So they were very anxious about having a child with disability. But when you compared them and that perception with the clinicians, what we noticed was that clinicians were willing to tolerate a much higher risk of having a major disability. And the reasons for that, in my mind, having read that article, are probably because we know that actually outcomes can vary, that we can't be certain of those outcomes, and that 60% has a huge spectrum. The question is, when we speak to parents, do we actually convey that information to them, and do they understand it? That is an absolute crucial aspect of conversations that you're having with parents, is that sometimes when you go to counsel parents at extremes of viability, the conversation just becomes about survival and disability, not about what survival means, not what disability might mean, what a major disability is, what the spectrum of that might look like. And these differences in thresholds can hugely influence how parents make decisions, but they might also influence why parents might disagree with us when we counsel them. So it's a really insightful article. So what I'm going to do is, having gone through all of that, we're going to do our last case today. And I am going to talk to Gautam about this case. Gautam? So there's a couple who have come from the UK. They are a young couple. They are backpacking. The mother is 18. The father is 21. They've been together for about a year. They are, let's assume, in a very remote part of your state. They've been backpacking. It's near the coast. It's very far away from any tertiary setup, but it has got a SNCU. And this SNCU is capable of resuscitating babies, 26 to 28 weeks. But they have resuscitated very few babies at and under that. And this is a mother who's actually 24 weeks pregnant. Now, she obviously, from her perspective, has gone into labor. She is in quite established labor at this particular point, having had some birth trauma, a fall. So she's kind of in the situation where delivery is very imminent, but it's early, and there is facility for tocolysis. There is also facility to give steroids, but no availability to give magnesium sulfate. The one thing is, obviously, this center has had only 4 babies survive below 26 weeks. And there is no facility for neonatal transport, no for tertiary care within a 1,000-mile radius. So you are the local pediatrician there, and I'm just keen to know how you're going to counsel the parents. Again, what I'm going to do is I'm just going to take you back to this framework that we have here.
Yes. Yeah. So yes, so first of all, we would since as the duty pediatrician over there, I would talk to the family, talk to the couple regarding the chances that the extremes of prematurity that the couple is in, that the mother is in right now, and also talk them through the process if the baby is born. I mean, since the baby birth is imminent, what would happen later on. If the baby and if they are able to afford if they're able to afford I mean since it's an SNCU and the chances I would also present to them the local statistics that I have that we have not resuscitated prematures so much, and the survival rate was only few. And I would talk, and with this available information and with the available limited resources, once the baby is born, the baby would require respiratory support. If not, since we also have a facility for tocolysis and prolonging the labor, I would advise them on tocolysis as well as antibiotics, to prolong the pregnancy for a little while, so that the limits of the lower threshold is crossed, so that once the baby is born, the baby has a better chance or a better outcome with the limited respiratory support that the SNCU has. And I
Okay.
think
So,
I think it's a challenging decision to make.
yep. So you counsel her, you actually give steroids, and actually tocolysis is successful. Now, clearly from your perspective, you recommend that she have bed rest. She's in a situation where, and actually the baby started moving well. You have facilities for ultrasound there, so you can do Dopplers, you can assess growth, and the baby's continuing to grow well. And the recommendation from your perspective is that she have at least 2 weeks of rest. And if that's all possible, so they decide to stay there for a few days, everything recovers, and she's kind of in the situation where they stay there hypothetically, they don't actually go to any other city. And then at about 26 weeks of gestation, having been there on bed rest, she goes into established labor. Now, what the parents were very clear about when they spoke to you the first time is, based on your survival, the risk of morbidity, and the lack of, I would say, intensive care facilities of the kind that they would get in the UK, they were very worried about the risk of a very poor outcome and the risk of neurodisability and the risk of taking the baby back. So there was an agreement with you in principle that if the baby delivered at 24 weeks, you are happy not to resuscitate the baby, uh, which, based on Indian law would be perfectly reasonable. The baby is now 26 weeks. Okay. It's a baby boy, steroided 2 weeks back. Uh, the estimated weight is 1.1 kilograms, really good sized, moving well, good liker, no risk factors for sepsis. But the mother has gone in to very established labor. Uh, she's in a situation where it's highly likely that she's going to deliver in the next, I would say, 12 to 24 hours. You're still without the ability for neonatal transport, but survival for 26 weeks at your setup is much better. It's about 50%. So I'm just curious. The parents are still of the opinion that they don't want their baby resuscitated because of the risk of neurodisability. So how would you approach that? And would you be comfortable supporting that decision? You're going to have to unmute yourself, Gautam.
So yeah, so at this point, I would advise them against not resuscitating the baby at this point, because we can show them statistics that from the center that we currently work in, the chances of survival for 26 weekers are pretty good, and with and the baby, has a chance, being a good weighted baby of 1.1 kilograms, a better chance of surviving with minimal respiratory support if needed. If the baby comes out good, if the baby has a good cry and a good tone and a good color and with a good, sensorium, the baby would do well. And the baby needs to be on follow-up for the neurodevelopmental assessment. But if the baby is a good starter, then I would advise them to go ahead with the resuscitation and to allow us to give active resuscitation so that we are able to save the baby. And obviously,
Can I
with the
yeah, can I push you a little bit more now?
Yes.
So to kind of say that
Sure.
you've said that, and the parents are still quite
Mhm.
adamant that if the baby is born, they would not like it supported because we can't accurately predict a perinatal outcome and neurodevelopmental outcomes for this baby. Obviously, the worry of infection, other factors. This is obviously survival at 26 weeks, as you've counseled them, and
Yes,
you've told
yes.
them that actually the risk of having severe disability, 9 in 10 don't, and that actually he might not need respiratory support. But they are of the opinion that being a young couple, they do not want a baby with any disability. So my first question to you, and I'm going to get you to write them down and think about it before I go back to Leva, is it legal for you not to resuscitate the baby in India? Number one, at this gestation. Number two, considering all the circumstances, the lack of our ability to be accurately able to predict neurodevelopmental outcomes, the fact that this baby, if it needs and gets tubed and has complications, might develop a higher risk based on where it's delivering. You don't have the numbers to be accurately able to predict in your setup at the SNCU what neurodevelopmental outcomes are. And clearly, this baby, obviously, if it survives, moving it to a tertiary center is extremely difficult, not impossible. The parents can pay for it, by the way. So, there is an option if the baby survives for the parents to pay for it. So I've just put those things in there. So A, is it legal for us not to resuscitate the baby? B, I would like you to have a think about the fact that these parents want a child with no disability and have come back to you after the second conversation again and how you would approach that. So give it 5 minutes. Leva, I'm keen to know your thoughts. What do you think?
I think this is an extremely difficult situation because if these are parents from a developed country like the UK, they will have actually thought their pregnancy was going to be managed like in the UK, but knowing if you're backpacking in India, well, that can't be the case. But also, does not every parent want a baby without a disability? And you can never guarantee that even if it's a term baby, it might still go wrong. You might still have a baby who's got HIE and is severely disabled. So I find it in some way sometimes difficult to manage the expectations of a parent to say, I do not want a baby with a disability, because you never know in whatever situation you are.
Absolutely. Kenichi, what do you think about this situation? So parents don't want resuscitation. 26 weeks in your setup. They don't want a child with disability. How do you approach it?
Actually, I agree with Nivel about it's really a very difficult situation. But it's all about talking to them because, like she said, that the baby comes out 10 does not rule out the chances of being disabled. A 10 baby can still be disabled. I actually think that one of the things as the major issue is that there's this already thought out idea that preterm babies are going to have disabilities. It's if within that 2 weeks that this mother was on admission on bed rest, that's actually the time to review literatures. Give them time, talk to them, give them things to read, and see if you can change their mind. In my setup in Nigeria, once there is life, we are bound to do something, unless the prognosis is bad. Like a child, if the child comes out very bad, multiple congenital anomaly and all that. But in my country, you're bound to do something. I've been caught in a web. Sometimes, some 6-7 years ago, the tertiary hospitals were on strike. I don't know if I have time to share
You do.
this
Carry on.
experience.
Yes, please,
Okay,
please.
okay. I was caught in a web. The tertiary institution were on strike. I was working in a missionary setup then, and they brought in a 26-weeker twins, 1 kg, 0.9 kg. One just died. I had just one left. The medical officer that was in the hospital just told me that they have an incubator that has not been used. Let's do something. If we don't do anything, this baby will die. If we do something, this baby might live. And there we cleaned up the incubator, moved the baby into a room with the mother, constructed our local bubble CPAP, the modified bubble CPAP. This baby stayed with us for about 6-7 weeks and went home. And we are still following up the baby neurologically. Baby is doing well. So it's just talking to them and using evidences that we have. It's more difficult for you in the UK where they know so much. But here, what my people want is for their baby to be alive. They're not interested in the neurological outcome. They're more interested in the baby being alive and to see what the baby will become. So it's a different ball game altogether. But I think that as doctors, we should do something. But try to talk to them and do what you can do and see what happens. Thank you.
That's really helpful. And it brings me back to the slide on parental perception. So if you look at the slide on parental perception, clearly what we have to understand very carefully is what parents want. Now, I'm going to put Gautam in a real quandary here because clearly he's explored that frame with the parents. And for them, they do not want to accept any threshold of disability. So Gautam, first question to you is, would it be legal for us not to resuscitate this baby?
No, it would be illegal because the current guidelines say that the limits of viability is 24 weeks. So
I'm curious. I've read the literature and I've been looking for guidance from India. And I would be really grateful if you can share that with me, because viability per se in India is still defined as being under 28 weeks.
Yes, viability is still 28 weeks, less than 500 grams. I mean, we currently have a 24-week, 530 grams. Actually, this mother had come with severe abruption. She was a G3 with two alive kids. This was a abruption placenta, and then at that time when we counseled and when we told the outcomes of this baby, they had asked us to go ahead with resuscitation if the baby had a good heartbeat.
So my
I'm
question,
sorry, I'm just sharing.
It's really, so my question to that is, and clearly all of us default to our experiences, but the question is it fair for us to use our experiences in that situation, not our judgments or outcomes for your setup, your experiences of one survivor, and there might be more, forgive me, I might be making a judgment here to counsel those parents. My understanding is that if I were to take the legal viability law, it would be legal to let this baby not be resuscitated in India. My question to you is, would you feel comfortable doing that now?
No, I wouldn't. I think I would be honest and tell them that this baby has this baby has now a good chance of survival with the care that we are able to provide in the SNCU now currently. So I would say that the option would be to go ahead with resuscitation and provide active care that the baby needs, and the baby has got a good chance of survival. I mean, we cannot predict that which baby would have disability.
So legally, where do we stand? I mean, who makes the final decision? The parents are still adamant. So is it their choice or your choice? What do we do in India?
I think it would.
Or your setup. Let me not broaden it to India, because India is a vast country.
Okay. I think at that place in time, it would be the doctor's choice to go ahead with the resuscitation. the pediatrician's choice to go ahead with resuscitation and give care. That's all. I mean, I think it would be our choice to go ahead with resuscitation.
Okay, that's really helpful. Does anybody want to add anything? Do you have any questions at the moment from this case scenario that you'd like to ask me?
I would want to know what you will do.
So what I'm going to suggest is when we do the next talk, I will open with this question and it's part of the MCQ. So if I give you the answer now, I won't get your real thought process, but it is an actual case that took place in India. So I'll be able to give you the actual outcome. But for today, I'm going to leave it here just so that we can get you to answer some of the questions that I'm sending you. A little bit more food for thought, as well as for the participants who've not been able to join us today. So I'm going to leave this with a little bit of suspense, as it will be interesting to see what they think. The one thing that I did want to just clarify before we finish is the concept of gestational uncertainty. And this is something that might crop up whenever you're talking to parents about extremes or limits of viability. Now, a general consensus from our perspective is that survival under 22 weeks with the best of technology is extremely poor. What you've got is case reports of survivors. As I've previously discussed, our estimates of gestational age are based on LMP, dating scans, but there will be situations where neither is available. It's an unplanned pregnancy. It's a pregnancy that was concealed, or it was a pregnancy where clearly the mother didn't find out, quite early on. So at that particular point, when you have to make estimates of gestational age, again, it would be a very late scan. And, scans above 18 weeks are notoriously unreliable. So, if that's one problem. The other problem is the mother might not remember her LMP. And really, what you'd then be doing is examination, fundal height, some other kind of clinical approaches that obstetricians do to try and make a rough guesstimate of where this mother's gestation lies. Now, my question to you, and I'm going to skip this slide, is if that is the case, how we approach it. Now, there are guidelines, and I'm going to share these slides and the guidelines with you, but clearly from our perspective, where you estimate and make an estimate of gestation, you counsel parents based on that clinical estimate. And a lot of, I would say, institutions, if they felt the baby was above 22 weeks of gestation, the default position would be to support the baby until you've seen the baby's condition at birth and you've been able to make an estimate of its gestational age clinically. The difficulty with that, and I've been in that situation twice in my career, is it's very difficult. You can't do a do-over-wits, and you cannot do that examination in such short periods of time. So in both situations, the default position has been to start resuscitation with a view to getting more information to be able to counsel the parents in those circumstances. Most importantly, what I want to highlight to Gautam is, Gautam, you spoke about that 26-weeker and starting resuscitation. So there is an option to redirect care even afterwards. And you have more information available to you at a later stage to be able to guide you with that decision-making process. So, I think it's not unreasonable for you in situations like that to guide the parents, as you've just done, to say, let's look at the baby's condition when it comes out, because actually we'll have more, information after resuscitation about the actual condition of the baby. But similarly, where you don't have enough information gathering can happen after resuscitation has been started. A key approach that I will share with you, is the fact that you can discuss parental wishes with regards to resuscitation if you have time, but if you don't, there will be situations where you initiate resuscitation. Some babies might be too immature. I'm going to give you a simple example. I've been recently involved in a resuscitation of a baby of 500 grams where, we struggled to get a tube in. And really, the baby eventually had a diagnosis of a tracheal stenosis. So that is a baby who's telling you that I'm too immature to survive, or I've got another problem that. So it might be that actually you initiate resuscitation, and then it's the baby who's making that decision by not responding to your appropriate, effective resuscitation response. But where time permits, I would say that if time permits, an expert clinician with experience in managing babies with extremes of viability, should be present along with the multidisciplinary team. And you must try to make as accurate a picture of the estimated gestation, as well as those other factors. You know, is this a girl or a boy? Plurality, weight, other factors that make the prognosis for this baby worse. And you'd counsel the parents based on that. But a lot of us would sometimes leave decision making to the point at which the baby is born, looking at how it responds to resuscitative efforts. In that situation, it's important, if time permits, to discuss with the parents what they want. And you know, it might be that you don't have time for this. And if you're in that situation, initiating resuscitation as the default process does not consign you to continuing neonatal intensive care. You can gather that information and then redirect care at a later time. So it's just one approach. Again, very nice, I would say, recommendations made in both the BAPM guidance around uncertain gestation as well as the Victorian guidance, all of which is there and available. So I'm going to end there. Any questions?
Well, mine is not a question, just to say that it's been very enlightening listening to the topic, the discourse. And these are things that I face here in my center, where you have really little or nothing to work with, and you're faced with challenges of extreme preterm babies, and you've got to do something. And my position also, or our situation here, is that the parents want you to do something, even when the baby is less than 26 weeks. You just have to do something and hope for the best. Thank you very much.
Not at all. And I would say respect to you, because, you know, the circumstances are extremely challenging, and, you know, we can't imagine being in your shoes. So, you know, the work that you do is God's work in reality, is what I would say. I'm going to end here. So again, what we'll be doing is, there's another talk tomorrow, which would focus on the approach to limits of viability from an Indian perspective. Again, ethical decision-making framework. So what we've discussed here is more of a kind of ethical perspective from, I would say, 22 to 26 weeks perspective, giving you a limits of viability approach for what is a developed country. So don't worry if you can't attend. I know that people are in and out, but this and all of it is recorded, will go up on the website. The only thing is, if you haven't finished the first MCQ, I'd really appreciate if you can. And we'll be sending out another 5 questions after this, with a view to moving on to the next topic in our teaching, which is going to be a focus on survival figures, survival in particular in the context of historical survival, but actually how survival is improved. And we're going to give you a flavor of developed and developing countries to give you an idea of what is happening over time. Thank you so much.
Thank you.
Thank you.
Thank you very much.
It's a pleasure. Take care.
Okay, bye everybody.
Bye.
Bye.